Hello, my name is Dr. Neil Mehta, and I'm an associate clinical professor of medicine at UCSF in the Division of Gastroenterology and Hepatology. And it's my pleasure to speak to you today in this virtual HCC course on downstaging for hepatocellular carcinoma, or HCC, and try to talk a bit about the effectiveness of downstaging strategies as well as potential limits. Here are my disclosures. So in this talk, I'd like to go through the management of patients with intermediate stage HCC, or basically patients exceeding conventional liver transplant criteria with an intent to downstage approach. We'll briefly chat about the updated Barcelona Clinic's liver cancer staging classification. We'll talk about transplant selection criteria worldwide, as well as downstaging criteria. And we'll try to update you all on outcomes related to downstaging in patients exceeding conventional downstaging criteria. And maybe end talking a little bit about how we might try to consider combining systemic therapy with a downstaging approach. I'd like to start with a case. So this is a 62-year-old patient with hepatitis C cirrhosis who had a variceal bleed in 2017, but has done really well since that time and now has small varices and has no prior ascites or encephalopathy. So relatively well compensated recently, and was able to be treated and cured for the patient's hepatitis C a couple of years ago. On surveillance imaging, the patient's found to have a multifocal liver cancer involving both lobes. The largest lesion's about 3 centimeters, but there's several lesions with a total diameter of 9 centimeters. The patient has presumed bland segmental portal vein thrombus, so meaning there's no tumor considered in the vein. And it does not appear that there's any metastatic spread or, as I mentioned, venous vascular invasion. The patient has excellent functional status and works full time. And then I posted the patient's labs here, including relatively close to normal labs, including bilirubin of 1.5, albumin of 3.5, INR of 1.3. Platelets are slightly low at 100,000. And so overall, the patient is a Child-Pugh A6, kind of well compensated with low MELD score. And the patient's alpha-feta protein is 15. So when we think about a patient like this, we have multiple different staging systems that are available to help us understand what's the patient's current stage. I've mentioned, I show 7 different options here, but the one that's most commonly used in clinical practice is the Barcelona Clinic liver cancer system. It assigns treatment to prognostic subclasses based on an assessment of liver function, tumor burden, and performance status. And it's by far the most widely cited, used in research. And also it was just updated in the Journal of Hepatology. And so I've shown the updated BCLC staging classification here. Now, this is a talk on downstaging, and so we're really not talking at all about very early stage or early stage cancers. These are patients who don't need downstaging. They're already typically liver transplant candidates. And I'm not really going to focus on advanced stage patients with extrahepatic spread or portal invasion, because these also are typically not patients being considered for transplant. So really in that case, we're going to focus our efforts on intermediate stage BCLC B patients who are multinodular with relatively preserved liver function. And in the latest update, they really nicely highlight what are those 3 types of patients that we need to consider. So on the right, there are patients who have diffuse, infiltrative, extensive liver involvement. These are probably not patients that we're going to be considering for downstaging, and instead probably are best served by systemic therapy. However, the other 2 candidates, specifically within this intermediate stage, are patients who are kind of meeting extended liver transplant criteria based on size and alpha-feta protein, who you might consider going straight to transplant, as well as a similar category of patients who may benefit from different local, regional, or downstaging treatments such as TACE. And then if the patient's downstage, then the patient could go to transplant. So that's kind of the concept here. So, what are the most commonly used options? Well, certainly transcatheter arterial chemoembolization, or TACE, is a common one. This is when, as you can see here, you do selective embolization of the hepatic arterial supply to the tumor via the common femoral artery into the hepatic artery, into the segment or segments that are supplying the tumor. And then you can inject different cytotoxic agents, doxorubicin, for example, and if you're doing conventional TACE, that would be mixed with Lipiodol or gel foam. And you can have a post-TACE complications such as fever, abdominal pain, infections, if the patients can decompensate, and also there can be abscesses or arterial injury as well, but these are relatively uncommon. On the other hand, the new kid on the block, the more recent advance in this field of intra-arterial therapy is radiation, specifically Y90 or yttrium-90 radioembolization. So this can be done either through glass microspheres or resin microspheres, so Theraspheres or Searspheres. And the radiographic response rates are excellent. And patients appear to have a clear survival benefit, though there is a small risk of radiation damage. So typically, we like to use Y90 if the bilirubin is under 2.5 or 3 milligrams per deciliter. And we do ahead of time, especially in patients beyond conventional transplant criteria, we will do a macro aggregated albumin study to calculate the shunt fraction to make sure that you're not going to put too much radiation in places you don't want it to go, like the brain or the lungs. There's been a few head-to-head trials comparing these two modalities. This is the most commonly cited. It's a very small randomized controlled trial with only 45 total patients. Conventional TACE and Y90 were the two arms. And you can see in terms of time to tumor progression, Y90 was performed much, much better with highly significant, even though despite the small sample size. This study was stopped early because they were not able to accrue enough patients, but Y90 seemed to really have a much longer time to progression. But on the other hand, when they compared intention to treat survival, we did not see a difference at all. And that was expected. The authors noted that they would have had to have a much, much, much larger study size to see a survival difference. So with that being said, I wanted to kind of shift gears a little bit to liver transplant selection criteria. So keeping in mind some of the different downstaging approaches, but the first concept to think about is, do we even need to bother with downstaging? Can we just take the patient who's beyond, for example, Milan criteria, and can we just transplant them right away? Well, certainly that is an approach that's reasonable. There's been several different expanded criteria that have been proposed, including the UCSF criteria, the up to 7 criteria, and several others. Most of these are based on slight expansion of tumor burden beyond Milan, as well as other criteria, such as perhaps using tumor markers like alpha-fetoprotein or DCP. The extended Toronto criteria uses biopsy, for example, of the largest tumor, make sure it's not poorly differentiated. And with these approaches, you can see that you do get pretty acceptable post-transplant survivals, but typically these are slightly worse than using the Milan criteria. Nowadays, in a lot of parts of the country, a lot of parts in the world, expanded criteria is not commonly done. And there's a few reasons for that, but one of them is that often we don't have access to immediate transplant. There's usually a wait time. And also, we're not able to get a sense of tumor biology if you just do immediate transplant. So we may be selecting with expanded criteria for certain patients who are going to do poorly with transplant. This is kind of a larger proposed selection criteria list. And again, there are quite a few. Here I've mentioned a few of them already, but just so you're aware that, and some of them are mostly studied in the live donor transplant population, but there are many, many different selection criteria. This is one that's gotten a lot of press recently by Mazzaferro and colleagues, a multi-center study published in Gastroenterology. And what they showed with expanded criteria is that you can push the envelope as much as you want. Consider like, the Metro ticket, the idea that you can hop on the train, and the further you push the envelope, or the further the train ride, the bigger the price you pay in HCC specific survival. So every kind of center and country has to decide for themselves what are their specific criteria that they want. So when you have the number of tumor nodules summed to the size of the largest nodule, as well as alpha-fetoprotein, you can see that as you have more tumor and higher AFP, it makes sense that you're going to have more recurrence after transplant and worse survival. So centers and countries have to decide how much they want to push this. And so our patient, you could decide. So for example, if you have a patient with number of tumor nodules, sum to the size of the largest nodule, this patient, for example, that I'm showing here would have an AFP of 250 and some nodules up to 7. The patient I presented earlier would be a little bit further along in this cascade. So what about live donor selection criteria? So what about if you actually have immediate access to a donor, a live donor? Is it reasonable to consider pushing the envelope here and going forward with live donor transplant? So this is a criteria proposed by Dr. Bangi from Medanta in India. And what they found is that 3 criteria were very useful for determining whether a patient would do well with live donor selection criteria, including AFP over 100, and if the patient actually would undergo a PET scan, PET positive, and then is the patient beyond UCSF expanded criteria. So these are patients, so I mentioned earlier, our patient had an AFP under 100. We haven't done a PET scan, but it does appear that the patient's beyond UCSF expanded criteria. So this is a patient that you might do a PET scan on, and that might help you, because if the PET scan shows PET positive disease inside the liver, then now you have 2 strikes, and this is a patient who is kind of more like moderate or maybe even higher risk. And so this is a patient that you might hold off on a live donor transplant immediately. And so a PET scan could be useful before live donor transplant. But what about if we're not really pursuing expanded criteria or live donation immediately? Well, then downstaging is the key here. So again, we had a patient who initially exceeded Milan or conventional transplant criteria. And what the goal here is to try to reduce the size of tumor using local regional therapies to meet acceptable criteria for liver transplant. We would grade the tumor response for downstaging based on the radiographic measurement of the size of all viable tumors, not including the area of necrosis from local regional therapy. So you don't count what looks dead, you only count the tumor that looks alive after treatment. And we think that downstaging is an excellent selection tool to identify patients with tumors with more favorable biology, who are responding to downstaging treatments and who are likely to do well after transplant. This is the key point here, okay? It's a selection tool, because if a patient has a TACE or Y90 and then the next scan shows more tumor, that's probably not a patient that certainly didn't get downstage, but also is not likely to do well with transplant. So at least in the United States and in many countries in the world, conventional transplant criteria is the Milan criteria, okay, single lesion up to 5 centimeters or 2 to 3 lesions up to 3 centimeters with no extrahepatic disease or vascular invasion. In the United States, we now have standardized UNOS downstaging criteria, UNOS standing for the United Network for Organ Sharing. So this is our national policy where patients are just beyond Milan, for example, 1 lesion from 5.1 to 8, or 2 to 3 lesions up to 5, or 4 to 5 lesions up to 3 centimeters with total tumor diameter up to 8 centimeters and no extrahepatic disease. So these patients, I'd like to show you some data. So this is our UCSF data that Francis Yao and myself and others published, showing that the downstage group, patients who initially met that UNOS downstaging criteria, once they get downstage to Milan, they do exactly the same after transplant, 5 years after transplant, as patients who are always within Milan, okay? Also, we then confirm these findings with a multi-center from our region in the United States, from multiple centers in California. And again, we showed in 110 patients who were downstaged and then underwent transplant, they had 80% 5-year survival with relatively low rates of tumor recurrence. So this was a very exciting time to show that downstaging really can work. But we did also identify in that same publication a subset of patients who likely are not to do well with transplant. We identified that if patients have there's 2 risk factors: decompensated disease, so Child-Pugh B or C, and then if their AFP prior to treatment was over 1,000. So these are the risk factors. So if they had both risk factors, all of them, it was a small subset, but all of them died very soon and were not good candidates for downstaging. And so we think if patients meet these 2 criteria, they're probably not good candidates for downstaging, but everyone else seems to be reasonable if we think once they are downstaging that they'll be good liver transplant candidates. This is another study published recently from Mazzaferro and colleagues in the Lancet Oncology that basically did a randomized controlled trial. What they did is that from 2011 to 2015, patients who were initially beyond Milan criteria, but had either partial or complete response to local regional therapy, were randomly assigned to either transplant or non-transplant therapy. So 45 patients. You can see here that the red arm, so all of these patients were downstage, but the red arm were patients who were offered transplants, and the blue arm were patients who were not offered transplant. And you can see clear survival differences between the two arms. Okay. Quite impressive, both overall survival down here as well as tumor-free survival up here. So basically, the concept is once you're downstage, you probably have to do transplant to solidify the benefits. Otherwise, patients aren't going to do as well. So this is basically the concept now that's being employed in multiple countries throughout the world, where you have certain downstaging criteria. You use local regional therapy for downstaging, and the goal typically is at least within Milan criteria, but you can do more downstage or more treatments with the goal ultimately maybe to try to have a complete tumor response. We typically will observe patients for at least 3 months, and along this pathway, they can drop out due to tumor progression, for example. And as long as they maintain tumor within transplant criteria, then ultimately they'll undergo transplant. And the expected 5-year survival would be the same as patients within Milan criteria who did not undergo downstaging. Because of these findings, patients in the United States are now automatically given exception points if they initially met UNOS downstaging criteria. This is now national policy. In the United States, so we have a multi-center evaluation of reduction in tumor size before transplant. It's called the MERITS LT Consortium that I'm the PI on, but we have multiple sites throughout the country in multiple regions. And the goal here is really to understand the feasibility and effectiveness of downstaging. We to date have about over 200 patients that have met UNOS downstaging criteria, with a very, very high probability of successful downstaging of almost 90%, meaning we can get most patients to within Milan criteria. We did an evaluation to see if there's any differences between patients who were offered TACE or Y90 initially, and there was not. The one caveat here is that we did see pretty high tumor understaging. Basically, we thought patients were downstage to within Milan, but on explant, there's many who were actually beyond Milan. And so this is something to be aware of. And this was actually because the more tumor you have on explant, the more likely you are to have recurrence. And so this is a signal here that suggests patients with significant viable tumor within Milan likely should continue to undergo local regional treatments to try to achieve complete tumor response if they can tolerate it prior to transplant. So a reminder of our patient case. This is the patient who had multifocal HCC, but a total tumor diameter up to 9 centimeters. In this case, this is patients who are beyond UNOS downstaging criteria because their total tumor diameter is over 8. And so this is what we would call like all comers or someone beyond UNOS downstaging. So when we look at this in our national database, only about 3% of patients meet this criteria. And when we looked at our UCSF data, it's the patients who are these all comers beyond UNOS downstaging criteria do not do as well. They have pretty poor 5-year survival of only 20. And the more tumor you have, the harder it is to get them downstaged. So this is a sum of this number of lesions plus largest tumor diameter. And so in our case, our patient had, the more tumor you have, the harder it is to downstage patients, which makes sense. And then when we looked at 3-year post-transplant survival in the UNOS database, you can see here that the Milan and downstaging groups were pretty similar, no significant difference, about 80% at 3 years. But the all-comers group did have a detriment in survival, only 71% 3-year survival, which is still okay, but not as good as the other two groups. So there's a signal here that there's inferior outcomes in all-comers. There's probably an upper limit in tumor burden, which exists beyond which successful transplant after downstaging becomes less and less likely. We see significantly worse rates of downstaging, worse intention to treat survival, higher waitlist dropout, and worse post-transplant survival for all comers compared to Milan and UNOS downstaging patients. So this is a key concept, and it's why I wanted to finish the talk by introducing the idea that perhaps we could, now that we've had such advances in systemic therapy recently, perhaps we could add systemic therapy in this population who are beyond conventional downstaging criteria to these so-called all-comers to help improve outcomes. Unfortunately, I don't have any data yet, but this is our planned clinical workflow within our consortium, where we'll take a select group of high-risk patients beyond Milan, so all comers, for example. We'll apply downstage treatments, and if we're able to get them to within Milan, then we'll plan to add systemic therapy. For example, atezolizumab, bevacizumab is one now first-line therapy if they're relatively well compensated without high-risk varices. Or if they're more decompensated, there's other options becoming available. I've just listed a few here. There's also the Himalaya trial that may make durvalumab an option. So these options will change, but the goal is try to keep patients within conventional transplant criteria like Milan, and you can do additional local regional therapy at tumor board discretion. But there is a concern that if you give patients immunotherapy too close to transplant, they could have graft failure and rejection. And so we typically will stop systemic therapy for at least 12 weeks before transplant. This is a key point here. If you stop their therapy and they can maintain tumor stage for 12 weeks, then we can transplant them. But if they have tumor progression, typically we'll exclude them from transplant. So in summary, patients meeting the conventional UNOS downstaging criteria have similar post-transplant outcomes after downstaging to patients always meeting Milan, but they do appear to have higher rates of tumor understaging. These patients do currently receive automatic listing priority after successful downstaging in the United States. On the other hand, patients with tumor burden exceeding the UNOS downstaging criteria, what I've called all comers here, must be very carefully selected for transplant. We should be considering additional local regional therapy, minimum observation periods, and perhaps even more stringent AFP cutoffs to ensure adequate patient selection for transplant. And given improved systemic therapy, there's been a lot of interest in combining local regional therapy with systemic therapy to improve outcomes related to cancer and transplant-related outcomes in this select population. Well, thank you. It was my pleasure to talk with you all today about downstaging, and including effectiveness and limits, and share some data from our group as well as nationally and internationally. This field of downstaging is rapidly evolving, and so it was my pleasure. And I hope you enjoyed this talk as well as the other talks in this hepatocellular carcinoma course. Thank you.